Thank you very much. Very, very long and a very kind introduction. The global number of absolute number of deaths from liver cancer is actually increasing. And the most important cause of liver cancer is hepatitis B infection. Our early study clearly showed that the mortality by liver disease, end-stage liver disease in Korea has decreased dramatically since the introduction of lamivudine, the first drug for hepatitis B. During the 14 years of span, the liver disease mortality decreased from more than 60%. However, the liver cancer mortality has increased for 18%. The absolute number of deaths by liver cancer also increased for 18% during the same period, which is very contrast to the remarkable decrease in liver disease mortality. This is very remarkable. And however, the age-adjusted mortality by liver cancer has decreased significantly from 2010 and 2020. However, this is because Korea has a very rapidly aging population. In terms of absolute, the crude death rate by liver cancer has not decreased. So we have to be very cautious in interpreting the epidemiological data, especially in the population with rapid aging. In fact, the absolute number of deaths by liver cancer has not decreased during the same period. Once the patients had developed liver cancer, the mortality rate is very high. And although the mortality rate has been improved during the last 3 decades, still the 5-year survival rate of the patients with liver cancer is below 40%. It is also important to note that mortality continues after 5 years from the diagnosis. So the 10-year survival rate is only 25% in Korea. Therefore, prevention is much more important than treating the cancer, where the best measure to prevent the cancer would be a primary prevention, which means eliminating the risk to develop cancer itself should be eliminated through the universal hepatitis B virus vaccination. Many Asian countries has implemented very successful universal vaccination programs, especially for neonates. However, the main mode of transmission of HBV is vertical from mother to child, which occurred at birth. Therefore, those generations who were born before the introduction of availability of HBV vaccine still have a high prevalence of HBV. However, the peak instance of HCC occurs at late 50s or early 60s. That means simply we can calculate that the problem of HCC should last for more than 20 years in the future, although we have very successful HBV universal vaccination programs. Therefore, we have to focus on the secondary prevention to prevent the HCC. The definition of secondary prevention is reducing the risk of HCC in the patients who already have the risk to develop the cancer through antivirals for HBV and HCV. Because the viral suppression is the first primary essential step toward achieving the goal to prevent HCC and mortality through undetectability of HBV DNA in the serum of the patients, we can achieve the normalization of ALT and the histological improvement and the reduction in HCC risk. Unfortunately, however, the global coverage, the treatment coverage for HBV is being reported to be only 2.6%. The main reason for this extremely low treatment coverage rate is low diagnosis rate in the world. In contrast, in Korea, the diagnosis rate for HBV infection is more than 80%. Nonetheless, the treatment coverage rate is still very low, only 21% in 2023. This is not related with the treatment acceptance by the patients, which is very high. And this is because of the very strict treatment indication, which is only can be applied to 35% of the total HBV-infected patients. Therefore, we may need the expansion of the treatment criteria. Current guidelines universally recommend to treat the patients only after identification of the ALT elevation above 2 times upper normal limit or just upper normal limit. However, many patients have high viral load with persistently normal ALT levels with increasing age. Therefore, these kinds of patients are classified as gray zone or indeterminate phase, especially when the patients have high viral load but persistently normal ALT levels, and that they are not indicated for the antiviral treatment. The very famous REVEAL cohort study, which was a prospective cohort study based on community in Taiwan, clearly showed that the risk to develop HCC increase stepwise as the patients have higher level of HBV DNA levels. The highest risk to develop HCC was when the patients had around 5 log IU per ml of HBV DNA. This association was independent of ALT levels and the E antigen status. If these data is true, we have to treat these kind of patients. However, these data has not been implemented in the guidelines or reimbursement criteria because of the unclear association between the higher viral load above 5 log and the HCC risk. Therefore, the REVEAL cohort study is very convincing. So the risk to develop HCC increases linearly as the patients have higher HBV DNA levels, up to 6 log IU per ml. However, all the experts believe that there is an immune tolerant phase, which means that the patients have very high viral load. However, the risk to develop HCC is very low. Therefore, these patients would not be indicated for the treatment. The problem here is that there is no scientific and consistent definition for the immune tolerant phase for chronic hepatitis B. For example, the American Association for the Study of the Liver defined immune tolerant phase when the patients have HBV DNA levels of over 6 log IU per ml and the persistently normal ALT levels, and the treatment is not indicated for this kind of patients. Therefore, the patients with 6 log IU per ml of HBV DNA should have a very low risk to develop HCC, which is very strange because the risk to develop HCC should change dramatically around 6 log of IU per ml of HBV DNA, which is really strange. In our study using by our own hospital cohort, we clearly demonstrated that the association between broad range of HBV DNA and HCC risk is not linear. It seems to be linear up to 6 log of HBV DNA levels. However, after that range, the association is reversed, and the overall association is non-linear parabolic, showing the highest risk at 6 log of HBV DNA levels. However, this was a retrospective cohort study, so we validated our findings by using the data collected from 3 countries, Taiwan, Hong Kong, and Korea, including REVEAL cohort study. in this study, more than 7,000 patients were included, and we exactly identified the same findings, which was shown by our own cohort study. The patients who had viral load around 5 to 7 log had more than 8 times higher risk to develop HCC compared to those who had very low or very high viral load. Our next study was focusing on the patients who started the antiviral treatment for hepatitis B. We were surprised to identify that the association between viral load at the initiation of the antiviral treatment was also significantly associated with the HCC risk during treatment, which was nonlinear parabolic, very similar to that was found in the patients who are not under treatment. We also validated our findings by using the collected cohort from Korea, Hong Kong, and Taiwan, which showed very similar findings. Therefore, we addressed the two important questions, whether the association between viral load and HCC risk is actually linear, but our answer was not was that it is not linear, it is non-linear, parabolic. And the second question was that once we initiated the antiviral treatment, the risk should be flattened to develop HCC. However, our answer was that the risk persists even after antiviral treatment. That means that once we initiated the treatment late, waiting for ALT elevation, the patients may progress from high viral load to moderate viral load. And even though we initiated the antiviral treatment, the risk to develop HCC in that patients may persist at a higher level. But these data were from historical cohort studies, so we wanted to produce higher level evidence by conducting randomized controlled trial. By the support by Korean government, we conducted large-scale randomized controlled trial, including the patients who showed viral load between 4 and 8 log, aged between 40 and 80s, and no evidence of cirrhosis. We randomized the patients, 780, into one of the two groups, early initiation of tenofovir alafenamide with normal ALT levels, or no treatment observation. 22 study sites from Korea and Taiwan involved in this study. At the first interim analysis at 4 years of the study, the baseline characteristics of the patients are summarized in this table, showing that the patients had completely normal ALT levels and HBV DNA levels around 5 log. And the results clearly showed the patients under tough treatment showed significantly a lower instance of HCC, decompensation, or death compared to those who were not under treatment. This was true even in the patients who had absolutely normal ALT levels at baseline. Therefore, we may propose to treat the patients who have a moderate viral load between 4 and 8 log to initiate immediately the treatment to reduce the HCC risk. Many patients have high viral load above 8 log. However, most of them progress to moderate viral load during natural course. And once the patients arrive to the moderate viral load, they may have irreversible increase in HCC risk. Therefore, if we want to prevent the cancer more effectively, we may initiate the treatment at high viral load, especially in the patients who are aging. The only group of patients who may be monitored without treatment would be those who have low viral load below 4 log. Therefore, the treatment recommendation should be simplified. We don't need to regard ALT levels. We may consider just age and HBV-DNA levels. If the patients have HBV-DNA levels around 10,000 IU per ml, all the patients are indicated, should be indicated for the treatment. We may also regard the age of the patients. And the cost effectiveness analysis have consistently shown that this strategy is very cost effective. If we apply this strategy, not considering ALT levels in the treatment criteria, the cost ISO value would be only around 2.5 thousand US dollars, and we can save more than 37,000 lives during upcoming 15 years. And even the patients who have a very low incidence of HCC, the treatment strategy is very cost effective. And if we consider both of the direct medical cost and the cost for productivity loss by premature death of the patients, the strategy is saving money, showing negative ISO values. Another study also clearly showed that patients who have a moderate viral load or high viral load could be indicated for treatment with a very high cost effectiveness ratio. This is HBV DNA level is the only only thing that we can change, because we cannot change the age of the patients. So the Korean Association for the Study of the Liver are revising our Hep B guidelines now, and we will publish our revised guidelines next year, early next year. After that, we will negotiate with our health insurance company to implement the expansion of the treatment criteria to improve the patient's outcome. In conclusion, current guideline recommendations to initiate antiviral treatment in Hep B patients have limited impact on HCC prevention. HBV viral load is one of the most important predictor of HCC development. And the association between viral load and HCC risk is not linear. Actually, it is parabolic, showing the highest risk at HBV DNA levels around 6 log. Our randomized controlled trial attention study clearly showed that early antiviral treatment significantly reduced HCC risk in Hep B patients with moderate viral load without ALT elevation. The increased HCC risk with a moderate viral load is only partially reversible even with long-term nuke treatment. Therefore, earlier initiation of antiviral treatment with high or low, around 4 log of HBV DNA may maintain the lowest HCC risk in patients. The simplified treatment recommendation for adult patients with HBV DNA more than 10,000 IU per ml, regardless of ALT levels or E antigen status, should be considered to minimize the risk of HCC. Thank you very much for your kind attention.